Thanks so much for having me. Again, just very briefly, my name is Kelkar, and I'm a stem cell transplant and gene therapy physician at Dana-Farber Cancer Institute in Boston, Massachusetts. And so we'll be discussing emerging cell therapies. First off, I have no relevant financial disclosures or other conflicts of interest. And now jumping in, I want to talk a little bit about the broader concept of transplanting cells, and then we'll go into specific cell therapies. Now, historically, when we talk about uh, bone marrow or stem cell transplant, we're collecting stem cells or the basic building blocks from our bone marrow that make all of our blood and immune cells, as well as platelets, and later infusing these cells into a patient. Autologous or auto transplantation is infusing a patient with their own cells that were previously collected. And in this type of transplant, we collect the patient's own stem cells before giving them very strong chemotherapy to kill as many cancer cells as possible. Because the treatment often or also harms the bone marrow, we then give previously collected and stored stem cells back afterwards to help the body and marrow recover. This works very well for certain cancers, especially types of lymphoma and multiple myeloma. Allogeneic or allo transplant is infusing a patient with donor stem cells. And here we use stem cells from a healthy donor, usually a sibling, parent, child, or sometimes an unrelated person who's a close match using our white blood cell or HLA type. The donor's immune cells help fight any remaining cancer cells and rebuild your bone marrow. And before this transplant, we give lower doses of chemotherapy or radiation to make room in the bone marrow for the donor cells to take hold. Now, there are newer versions and next steps to these therapies that are being evolved, and both transplants can be further tuned through things like giving additional T cells afterwards or training these therapies to recognize certain cancer cells. And that latter part is what we think of most of the time when we talk about cell therapies. We can also change or modify the genes in these stem cells um, using tools like viral carriers or CRISPR, and this turns them into a gene therapy. Now, we perform a lot allotransplants or allogeneic transplants for a lot of conditions, some of which we've heard about earlier today, but the vast majority of these are types of acute and chronic leukemias, myelodysplastic and myeloproliferative neoplasms, as well as other conditions like lymphomas, particularly T cell lymphomas. Now, we used to also perform allogeneic transplants for multiple myeloma, but there was a large clinical trial in the last decade that showed that it didn't provide enough benefit for multiple myeloma, and this is especially borne out given all the new and exciting therapies for multiple myeloma that you heard about earlier today. So we don't typically do allotransplants for multiple myeloma anymore, except in special cases. And then we also perform allotransplants for non-cancerous conditions for diseases like severe aplastic anemia, sickle cell disease, and other inherited white and red blood cell diseases, as well as for some autoimmune diseases, which is where the immune system attacks a patient's own body without them having a cancer. There's also auto transplants, as we mentioned, and we still use these to treat multiple myeloma and multiple types of lymphoma. And there are also ongoing clinical trials looking to use auto transplant for autoimmune diseases, with one recent study showing increased length of life in patients with severe systemic sclerosis. There was also one positive trial for auto transplant in breast cancer back in the 90s, but multiple large clinical trials have since shown that unfortunately there isn't benefit for using auto transplant in breast cancer. And while we're about to launch into talking about some of the newer cutting edge therapies, most of the cell therapies delivered are still these unmodified auto and allo transplants that cure a lot of cancers and save lives. And so that's why I wanted to make sure we at least touched on those so that you guys know that those are still happening. And that's the majority of what I do on a day-to-day basis as a clinician.